And before I call the next speaker, can I request Professor Abdul Samad to join us in the chairpersons? Professor Abdul Samad, if you're here, please. Okay. So my next duty is to call to talk on left main PCI, which has obviously been a bone of contention between the interventionists and surgeons, always been. And who else can talk better than Dr. Sohail Aziz on left main PCI, please?
Bismillah ar-Rahman ar-Rahim. Thank you very much. First of all, I must appreciate the wonderful gathering that the organizers, especially the President of Society, Nadeem Rizvi and Hanif Bashir, and all these wonderful people have, got this galaxy of people here. And in just this few hours, we've seen so much excellent talks, and I really look forward to this meeting. And I'm amazed at the quality of talks which have come here. And I'm sure that given the right opportunity, this could become a real major meeting internationally also. Greetings from the 4G Foundation Cardiac Center of Excellence. It's still coming up, but we started interventional work there. I have nothing to disclose. Basically, what is the left main stem? It arises from the aorta, the left sinus, and it has an ostium, a mid portion, or the body shaft, and a distal portion. And they all have to be treated rather differently. A very simplistic, definition of bifurcation is a main branch and a side branch. And what is a side branch? That which is something irrelevant, and that which is more than 2 millimeter, or a branch you do not want to lose, or which a surgeon would not ignore, because they will cause responsible symptoms, viability, ischemia, and LV function. It's about 5% in general angiograms, but isolated left main tend to be seen more often in women than men. Why is left main so different from the rest? That's because it supplies a huge amount of myocardium. It supplies maybe more than 50%. Its side branch, circumflex, is not just a side branch. It's a real major epicardial vessel. And God forbid, if that closes on you, you're going to lose a lot of function. It will also induce an acute MR, which will just create disaster. So it's very important that we look after the circumflex. And because the size of the left main stem, it actually is reaching the limits of what the normal stents are all about and what normal balloons we have. So whenever somebody thinks of a left main angioplasty, he must get the inventory right, the size of the balloons, the pot balloons have to be on the shelf. And when you select some, one of the biggest reasons why sometimes I avoid left main is if I think there's not enough balloon or stent size which will fit into this diameter vessel. Then there can be a trifurcation branch, which has to be dealt separately, and it has to be preserved. Then the trifurcation angle between the two vessels is very important. And in acute syndrome, there's a thrombus, so you cannot actually just treat it like any other bifurcation. You need to make sure that you take care of the thrombus also. And because of the large supply of myocardium, there's very little margin of error in this vessel, although everything is so accessible to you. You have to prepare the bed very carefully, especially in calcific vessels, and you need to use rota, sculpt, or cutting balloons or whatever, but you have to prepare the bed very properly. Otherwise, if you do not, there'll be high degree of stent thrombosis and ISR. These people tend to have low ejection fraction that just adds to the complication of the procedure. And it has to be very aggressively post-dilated. But by aggressive doesn't mean carelessly. You need to make sure that you do not damage the struts, because the stent doesn't like to be bent at all. The moment you bend it, it will damage and it will cause a lot of problem for you. And then for every bifurcation, there must be a backup strategy. I've known people not to be able to recross something, so they must have a strategy to back up every bifurcation they do. And it's very important to, if there's a bifurcation in your facility, you must go over it. And I would always suggest that when you do left mains and bifurcations, ask a colleague to join in. If he's junior, he'll learn from you. If he's senior, he'll just add more to your knowledge. So how do you select these patients for these procedures? On one end, we have a complexity of vessel. And on the other hand, we have the comorbids. So on an average, if there are a lot of complex lesions, we tend to go for a surgical option. If there are a lot of comorbids, we tend to go for PCI. And then, of course, there's a whole lot of in-between gray zone, and that gray zone is decided by more mathematically by the syntax score, global risk score. There's some risk calculators which are very useful and very handy online available, and the appropriateness criteria, and of course the guidelines. And so by and large, there are a huge number of guidelines, and I'm very happy that Professor Asad will be talking about them later. So I'll just touch on these briefly. That if you have a syntax less than 22, you probably in the European guidelines you have class 1 indication of doing a PCI. From 23 to 32, you have a 2A recommendation, and above 32 is class 3, which is a contraindication. But I will show you data which will suggest that syntax doesn't matter for left main nowadays. So there are more guidelines. So by and large, lower the syntax, better the outcome. And for austere and shaft, and it's very kosher for us to attempt PCI. But of course, I would again suggest that they should never go without a team meeting, heart team meeting. And this is what the heart team is all about. You have the cardiologist, the surgeon, the anesthetist, but if there's some comorbids, then of course the heart team becomes much bigger, and they all need to give their input. And with that, you do not just get informed consent. You need to participate and help make that patient make that decision. It is a shared decision making. I've seen people just telling them the pros and cons and make your choice. That's not probably the right way. You got to share this decision with them. You need to be part of it. You need to feel their, next slide would probably show a little more. So by and large, there's an algorithm which every tends to follow. It's based on the side branch. So if the side branch is good, you go for a provisional. And a provisional tends to be a very simple technique, just stent across the vessel and ignore it. But that's not what provisional is all about. For me, provisional is much more complex than a 2-stent strategy, because at any point in time, you need to switch over to a 2-stent strategy. And you do a provisional because it's a better outcome, not because you do not want to do a bifurcation. So you got to know your bifurcation before you can focus on your 2-stent strategy. So as soon as you start operating, you start dilating, you cross the wires, your strategy changes at every step. And you should be ready to rethink your plan and re-strategize your priorities. And as long as the side branch remains okay, you can continue and complete a provisional. The moment it's compromised, that can be just by visual or IVUS or OCT or whatever your modality you're using, you change to a 2-stent strategy, but have a 2-stent strategy ready, which is well rehearsed. So that's the usual team meeting, where the surgeon just refuses to accept and the cardiologist just refuses to back down. And it's hardly a very pleasant interaction. I've seen a lot of cardiologists complain that you do not bring your patients to our heart meeting, and then, we think that they do not bring their patients to our heart meeting. So it becomes a very tricky thing. So heart team meeting needs to be very intellectually honest with the patient's welfare at the bottom of all of this. And that's because we think that our equipment, our stent failures, our emergency bypasses, our restenosis, thrombosis, and late thrombosis are becoming so less that we are really this is the right time to enter into interventional cardiology, not the right time for people like Nadeem Rizvi and Harun Saab to be leaving this specialty. But, for young people, this is a great time to be in the specialty. And this is what is the worst case scenario, where the discussion becomes so exhaustive and so passionate that the patient gets really confused what he's doing. And you will find these people coming to you saying, I don't know what to do. And we end up adding more to the confusion. The biggest thing we got going for us is that nobody wants to have a surgery. That's why lap chole is so on, and why all those dental implants are so on, because nobody wants to lose a tooth, Like we just heard it, Professor Abid's lecture, great talk. I think after his lecture, my lecture is going to be reduced to half. There's so many classifications, but this is the most important and the relevant one, which is used very often. But it does not cover some things. That it doesn't talk about the lesion lengths, the angles in between, the size of the branches, the calcium, the diameters, the plaque burdens, which way the plaque's going to shift. So it has deficiencies, but it's a very good starting point. The other one is the MADS. MADS is really a wonderful classification. I follow this every time, and that determines where does the first stent land, and after that everything else follows. And after every stent implantation, the outcome can be a certain few stages and nothing more. So you got to be very sure where you want to plant your first stent in and then proceed from there. And with the new techniques going on, the MADS2 is here. A few things I want to talk about is that the side branch is relatively short, and I'm going to show you evidence. It's less than half a centimeter in most cases. There's a concept of pseudo-fractal object, which I want to talk about. And the carinal involvement by atherosclerosis is extremely unusual. These things you must keep in mind when you do bifurcation, especially for the left main stem. So this is data that suggests that in almost like 400 people, they found that the side branch tended to be less than 5 millimeter. So provisional was certainly on the cards. Then did IVUS evaluation, and they found that in 73 patients looked at, in none of them there was significant disease in the carina. So the carina tends not to have disease. It's the side portion which has. So that's a good way of working out which way the plaque's going to shift. And that's a pseudo-fractal. That means that everything divides with the common formula. That applies to trees. It applies to rivers, roads, canals, brain arteries, heart arteries, every artery, that they are divisible by the factor of 0.678. That's a universal factor. And that's how we came up with the Furness and the Murray law. So now some technical aspects. The approach, people would use femoral and radial based on how useful you are, how well you work. People do routinely bifurcation the left main with 6 French, but if you use a 7 French, it's always easier to manipulate the wire and push the equipment. If you want to have a third thing in there, you need to have an 8 French catheter. You got to go femoral. So you can do a sheethless entry with a 7 French with the balloon tip balloon at the tip, and you can advance the 7 French and do a very conveniently, and you can take it out. And I think in the last maybe 2 years, I've never used 90% of my volume has been sheethless entry 7 French from the arm. So sideband protection is very important, and bed preparation, like we said, has to be very important. You could use rota, cutting balloons, whatever, but make sure you get a good bed. You need to get a very good visualization, preferably with IVUS, OCT, FR, IFR. These things are very handy to have. Even if you don't have it, must go and work in a center and experience these, and then you can probably feel more comfortable with appropriate sizing. What we sometimes do is that when we're doing a high pressure inflation, we give a little puff of dye. And if you see a little puff of dye trickling down the catheter, your balloon is probably undersized. In that case, go half a size bigger or higher pressure and give a little more puff. And that's my poor way man's IVUS for me, but of course this is not documented. I wish we would work as soon as we get our IVUS in our place. The question of distal and proximal crossing. In distal vessels, you do a distal crossing. But in proximal vessel, left main, you always do a proximal or a mid crossing. Otherwise, you don't get a good carinal shift. That's very important. For distal vessels, distal crossing, but for proximal vessels like left main, proximal or mid crossings. Then, of course, kissing balloon inflation, we're going to talk about that. Left main stem, tool and kits, you need to have all the inventory. So before you go in the lab, make sure all that is complete. And, of course, the backup with the balloon or impala. If you don't, you sometimes need to, I always scrub the groin, even if I'm going radial, just to make sure. And some people put in a 4 French sheath if they think patient is very serious, just to make sure they have a quick access. We have to talk about the Excel and Noble trial. There were like 2 trials comparing surgery with left main stem stenting. The 2 had very different outcomes. And Nobel showed extremely good outcome at 3 years, and Excel showed very good 3 years outcome, but at 5 years there was some, the Nobel had a lot of difference, and it showed surgery was far superior, and there were a lot of flaws in that study as far as we're concerned. Of course, lawyers will find flaws in everything, but they used Cypher in the first 10-15% patients, and then there were only 25% of enrollment over 5-year period. So it became a really tricky trial to look at. So Excel looked at almost 3,000 patients, and when they did the syntax at the core lab, they found that they had decided to use only the less than 32 millimeter syntax score. But when they looked at the core lab, they found that a quarter of them had syntax of more than 33. So Excel actually covered all the severities of left main stem. And so this is the 3 years outcome, and at 5 years there was a little diversion, and surgery had a superiority. And that's something, although it's still not significant statistically, but this has to be kept in view, and you need to make sure that you counsel your patients accordingly. More data, and so a little bit of bifurcation. Bifurcation, 2 stents always had a bad outcome. The techniques we do now were not there in the Syntex trial, like DK crush was not even in the Syntex trial. And every study you looked at showed that 2 stents had a bad outcome, till the Nordic Baltic study showed that if you have a significantly critical side branch, then 2 stent strategy had a good outcome. And then, of course, the crush, which came out with the big bang with Antonio Colombo later because of his issues, it became mini, and then DK, step, and reverse. And then it was compared with other, and they found that SKS was superior to crush. Culotte was superior to crush. Again, we find that Culotte was superior to crush. And then Culotte was superior even to tap technique. But DK crush overtook them all. The reason is that they're just very small studies, small data, so it's not a very hard and fast. It's more to do with individual experiences and the techniques. So, but for now, DK crush seems to have the maximum data and the maximum outcome. So, by deploying, must stent the distal vessel, size the distal vessel before deploying the stent. You must do the pot, and the carina should be spared. So you must inflate proximal to the carina, otherwise you'll have difficulty in crossing the wire and the balloon. And you will get your wire under the struts also. That will be a real problem. If you want to recross the side branch, then try not to dilate it. And IVUS becomes very handy. We're just about to finish up, sir. And use a cutting balloon, but prepare a bed very properly. As the new generation of stents came on, the result was better. The everolimus outdid the sirolimus. Just by wiring the side branch saves the side branch. So that's very important. It stretches the outlet also, and it makes it less likely to occlude. And must always do a pot with an NC balloon, because otherwise with the semi-compliant, you will dog bone and not expand it properly. You must reassess the angle after wiring, because wiring will change the angle of the bifurcation. And like I said, distal lesion, distal crossing, proximal vessel, proximal crossing. And I think you must always kiss, because if you use a second inflation side branch, you will disembed the struts, and you have a real disaster on your hand. So rather than saying don't kiss, I think do sequential inflation. So if you cannot afford the second balloon or it won't cross, then this side branch, and then final inflation should be the main branch. So that's approximated well. So that's something, because that's the data I would want to follow, that you have to kiss. If you don't kiss, go sequential ballooning, and the main branch should be the last one to be inflated. And pull back as little as possible. Least metal is better for you. And so if you have difficulty in recrossing the balloon, just get the angles right. So the commonest reason is that if you twist the wire too much while recrossing, you'll entangle the 2 wires and the balloon will not. So sometimes you have to pull it back and recross. So don't be afraid to pull back and recross. And so in conclusion, a single stent with provisional is the real thing. Stents do not like to be bent and remain the strategy of choice of majority. D-crush and Culotte are the 2 favored 2-stent strategies, although every operator has his own experience. And TAP is for provisional. When 2 stents are required, any technique, if it's done properly, approximated, inflated, beds are prepared, it'll have a good outcome. It's more about your experience, how you do it. FR, OCT, IVUS helps in understanding the complexity and not a total must. And more attention should be paid to optimizing the chosen technique than to choose among the various techniques. So how do you talk to the patient? This disease is progressive. So you need to tell the patient that, look, it's not just the end which matters. It is the journey, how you travel. There's data. If you're going to live 20 years after your first procedure, you're going to have 3 procedures. The question is, which one are you going to have first? So because this disease is not going to be, then see, a surgeon meets him, says, look, have surgery, end of the story. That's the worst thing they can say. They need to be on statins and various drugs, because the grafts go bad very quickly. The disease is progressive. There's progression every year. So we got to make sure that we tell them that this is not the end of the story for you. You got to take your medication, and the real thing is what is the best choice. But I must say, the first procedure is very important, because the first procedure is the only procedure which is prognostically important. After that, it's always symptoms. So you must choose your first procedure right. If you do not choose it right, you will really have a mess up for your patient. Thank you very much.